Hello again, ladies and gentlemen, and welcome to case study number 38. This will be a patient coming in with a sore throat, a super common complaint that you will run into around October to January and in that period. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I really appreciate all the contributions I can get to help offset the cost of these videos, and I thank those of you who have already stepped up to donate and those of you who are considering it. Okay, we got a 17-year-old white boy coming in with his mother to the clinic complaining of a sore throat for the last 2 days. He says that he woke up with the pain yesterday morning and tried riding it out, but it has gotten worse and now he has cold chills. Review of systems is otherwise unremarkable. No cough or rhinorrhea. No significant past medical history, and he has never had mono. He denies smoking, alcohol, and illicit drug use. He's a high school student and is not sexually active. He's on no medications. He's tracking in the 45th percentile for weight and the 50th percentile for height. He's up to date on all vaccinations. Blood pressure 109/67, heart rate 105, respirations 14, temperature 101.9, and satting fine. Okay, now, we know that the vitals for a late teenager, 16, 17, 18, are roughly the same as an adult, so I didn't put any specific vitals here. What do we want to do now for physical workup? We can be pretty comprehensive. So generally, he's well-developed, no apparent distress. Lymph nodes, tender anterior cervical lymphadenopathy. So probably some infectious disease going on above the head. Head, eyes, ears, nose, throat, no conjunctival injection. White tonsillar exudates on erythematous tonsils. Neck is supple. Chest, lungs, cardiovascular, abdomen are all normal. Notable negative here. Spleen and liver, not palpable. And neuro, grossly nonfocal. Okay, what is our differential? We actually have a fairly wide differential, although there are a few things that are going to be most likely. So streptococcal pharyngitis is going to be towards the top. Strep throat is super common. You'll run into it all the time. Viral pharyngitis is another part of our differential. This is really a cold with a sore throat. Infectious mononucleosis, always something we want to consider in a teenager with the sore throat. And then you got influenza, COVID, some less common things like herp angina and retropharyngeal abscess, usually in younger kids. And if he were not vaccinated, we would want to consider things like diphtheria, epiglottitis, and measles all can cause a sore throat. Okay, so what is our workup? Well, we're considering strep and mono to be our number 1 and number 3 diagnoses. Viral pharyngitis is certainly possible, but we don't really have any way to test for it. So if everything here comes back negative, it's probably viral. So what we're going to do is a rapid strep antigen test. That will come back very quickly. And then a streptococcal culture, and that will take some time. Now, there's a pretty decent number of false negatives with the antigen test. So we get the strep culture because if he tests negative and a couple days later, if the strep culture comes back positive, then we will treat him. We're also going to get a mono spot. That's kind of another rapid test that can be a test for mono, and an EBV titer, kind of along the same lines of the culture. Okay, so what do we find? The strep antigen test is positive. So this is a diagnosis of strep throat. Now on CCS, you may see it listed as strep screen pharynx. That's the same thing. The streptococcal culture is pending, the monospot is negative, and the EBV titer came back negative. Okay, so our management here, well, first of all, we have a diagnosis of strep pharyngitis. We treat this with antibiotics. It's pretty straightforward. There are several antibiotics you can use. Penicillin is one, amoxicillin, obviously. Azithromycin is commonly given. That's the one I like to go for because you only have to take it for 5 days, whereas amoxicillin, you have to take it for 10 days. However, there's a lot of strains of strep that are becoming resistant to azithromycin because we've given it so often. So if the patient has a penicillin allergy, you can either go for azithromycin or you can go for one of those first-generation cephalosporins. Either are fine, but amoxicillin is a safe answer for step 3. Further orders are to reassure and counsel the patient. Acetaminophen is fine for pain relief, and he should stay home from school for a few days. Strep pharyngitis is a group A streptococcal infection of the pharynx, and it's characterized by an abrupt onset of sore throat and fever. Viral pharyngitis tends to be a little more insidious. It is most common in winter and early spring, but it happens any time of year, and I would say even late fall. You tend to see this a lot. The Centaur criteria is very commonly used for screening. So we look for 4 things: a history of a fever, a lack of a cough, that points to viral, tonsillar exudates, and tender cervical lymphadenopathy. This patient had all 4. So as a matter of fact, some people would say you don't even need to test them. If they've got all 4, you just go ahead with amoxicillin. Now, if they're 0 to 1, then a lot of people say don't even bother testing them because they're very unlikely to have strep. So you can follow that if you want, but I tend to go for just testing them if you suspect it based on clinical appearance. The best initial test is the rapid streptococcal antigen test. The most accurate test is obviously going to be a culture, and management is antibiotics. Over-the-counter pain relief can be used as well. Now, if we go on, okay, I got it right here. I just want to bring this up. So this algorithm is from the AAFP. Now, this algorithm says do a strep test. If it comes back negative, then go ahead and test for mono a few days later. But personally, and what I see clinically, is just to do the strep and the mono test at the same visit. You'll figure out the diagnosis based on the appearance, and then you're good to go. Another problem is that there is a number of patients who will get co-infected with strep and mono. There's a synergistic activity going on there. So I think it's useful just to test for strep, test for mono at the same visit. This shows you kind of the differentiators between strep, viral pharyngitis, mono, and influenza. What you can see here, the pertinent negative for strep pharyngitis is the absence of a cough, whereas for viral pharyngitis, you tend to have a cough. This is just a cold with a sore throat. It's an upper respiratory tract infection. Mono, look for that splenomegaly. It doesn't always show up, but it tends to. Lots of similarities between mono and strep. That's why I like to test both at the same time, especially when you're dealing with a teenager. So these are common differentials. Like I said, viral pharyngitis is really an upper respiratory tract infection with a sore throat. Infectious mono, very similar to strep, has a more gradual presentation. You may run into splenomegaly. They tend to look sicker. They have chills and muscle aches, even nausea and vomiting. They're just sick looking. So like I said, you can co-test with strep. If you do give them amoxicillin, let's say they're co-infected, a lot of times they'll develop this really generalized macular rash. COVID-19, look for sick contacts, loss of smell. Herp angina, which is a Coxsackie virus infection, tends to happen in younger kids. They'll have ulcerations in their mouth, and that can cause some dysphagia. And then a retropharyngeal abscess, that's usually in younger kids. Look for neck pain, muffled voice. So to recap, strep pharyngitis is a group A infection of the pharynx, abrupt onset of sore throat and fever. Look for the absence of a cough. The major differentials are viral pharyngitis, mono, and influenza. The diagnosis for strep pharyngitis is the rapid streptococcal antigen. And also remember to get the culture because there are false negatives with the rapid test. If it comes back positive, send them off with amoxicillin. If it comes back negative, wait for the culture. You're likely dealing with a viral infection. If antibiotics are given and a rash develops, presume mono. The complications of strep pharyngitis include scarlet fever, which would show up pretty quickly, and then these delayed complications, rheumatic fever, and post-streptococcal glomerulonephritis.